Hello everybody, my name is Ryan Averett. I'm a licensed clinical social worker in the state of Colorado, and today I wanted to make a video discussing why I don't do EMDR treatment with my clients. I've gone through the 50-hour EMDR training process, and I left that process with a lot of concerns and ultimately the idea that this is not something I want to do with my clients. And I get a lot of questions about that, either from clinicians or clients that I have who come seeking PTSD treatment. So I wanted to make a video outlining my general thoughts on this topic, and maybe this sparks some discussion on the topic, maybe it gets you thinking about the topic in a different way, or maybe you just think I'm wrong, but we're going to jump into it. Why I don't do EMDR therapy. I want to start out with a couple disclaimers. First of all, we will be discussing trauma today. And this is very sensitive for some people. Some people do not enjoy hearing about trauma, maybe because of their own past experience or for whatever reason. So if this is not something you want to be hearing about, click off the video now. Also, I'm not telling anybody not to do EMDR treatment. There's plenty of clinicians that do EMDR with their clients, and it works well, and they find it to be effective. I'm just outlining some of my thoughts and my opinions, so take them for what they are. Alongside that, I want to be very clear, many people have experienced success with EMDR treatment, and I want to say very, very clearly that EMDR is effective. We're going to get to that and have a discussion about why it's effective, but it is effective, so I don't want to take away from that. And lastly, I'm just a person. I can be wrong, and I'm also happy to change my opinion on some of this stuff if some different evidence were to come up. Now, insofar as we're going to talk about this topic, we're going to have to define terms of other topics too. So we're going to talk about what is trauma, what is PTSD or post-traumatic stress disorder, what is cognitive behavioral therapy or CBT. We'll discuss how CBT is applied to PTSD. We'll discuss why CBT is effective for PTSD. Then we'll go on to discuss what is eye movement desensitization and reprocessing or EMDR. We'll talk about how EMDR is applied to PTSD and why it's effective for PTSD. We'll talk about what is purple hat therapy. And lastly, we'll actually get to the topic of the video, why I don't provide EMDR therapy. Now, if you're a clinician, you might already know the answers to the first 7 topics here. So if you want to skip to the end, feel free to. But I want this video to be digestible for any layperson who maybe doesn't know how these things are defined. What is trauma? What is PTSD? What is CBT? There's plenty of people that aren't going to know the answer to those questions, and that's why I want to go through them. So, what is trauma? Now, we're going to be using the DSM-5's definition of trauma today. And the DSM-5 is a book that outlines the diagnostic criteria for different mental health disorders. The DSM-5 is not perfect. It's essentially a big book of diagnoses. And, well, I have a lot of opinions about diagnoses. I think fundamentally, mental health diagnoses are an instrument for insurance companies to be able to bill for mental health treatment. And that's totally fine. We need something like that exists. But the DSM-5 is imperfect. So, we're going to go with this imperfect definition of trauma today, simply because we need a definition, and it's something that we can roll with. So, according to the DSM-5, trauma is defined as exposure to actual or threatened death, serious injury, or sexual violence. And you might hear that definition and immediately think, well, that's a very narrow definition of what trauma is. And there's many, many people in our field that feel that exact same way. So we'll go through some examples of what would be recognized as trauma according to the DSM-5 and what would not be. Some examples of what would be recognized as trauma by the DSM-5 would be witnessing a car accident where somebody passes away, getting a death threat from somebody, breaking your arm in a climbing accident, or witnessing sexual violence. Those would all fit into the definition. But there's plenty of things that would not fit into the definition that we still think about as trauma. So you might think about emotional neglect, bullying, infidelity, a sudden job loss, a bankruptcy, a miscarriage, racism, homophobia, discrimination. All those would be examples that we might typically, in day-to-day conversation, think about as trauma, but the DSM-5 would not recognize as trauma. So insofar as we're talking about trauma today and PTSD today, we're going to go with how the DSM-5 defines it. Again, I know that this is imperfect, but we have to have some sort of working definition. the whole reason we define a trauma is because we're going to have to define what PTSD is. So we're going to go through what the DSM-5 diagnostic criteria for PTSD is, and briefly discuss each one. I'm going to try to be quick about this. The first criteria for PTSD is some sort of exposure to trauma, and that can be by direct experience of the event, witnessing the event, learning that the event occurred to a loved one, or repeated or extreme exposure to adverse details of the traumatic event. And that last one is kind of confusing, so you might think of examples like first responders collecting human remains, or police officers repeatedly exposed to details of child abuse. Those would be what fit into that last one. But you need one of these exposure to trauma. The next criteria is a set of intrusion symptoms. And to meet the criteria for PTSD, you have to have at least one of these. So it would be either distressing memories, distressing dreams, dissociative reactions like flashbacks, distress and exposure to cues or triggers that symbolize or resemble aspects of the trauma, or a physiological reaction to cues that symbolize or resemble aspects of the trauma. So you have to have at least one of these as well to meet the criteria for PTSD. The next criteria is avoidance, and that can either be avoidance to internal reminders, like distressing memories, thoughts, or feelings related to the trauma, or external reminders. So that could be people, places, conversations, activities, objects, or situations that are related to the trauma. You have to have exposure to one of these two, either the internal reminders or the external reminders. The next criteria is a set of negative changes in cognitions and mood, such as, and you have to have at least two of these to meet the criteria for PTSD. So it would be inability to remember important aspects of the trauma, negative beliefs related to the trauma, blaming oneself for the trauma, persistent negative mood and emotions, decreased interest or participation in significant activities, feeling detachment or estrangement from others, or inability to experience positive emotions. You have to have at least two of those to meet the PTSD criteria. Another one is increased arousal or reactivity, such as irritable behavior and angry outbursts, recklessness or self-destructive behavior, hypervigilance, an exaggerated startle response, difficulty concentrating, or sleep disturbances. And this is another one where you have to have at least two of these to meet the PTSD criteria. The last sort of set of criteria are kind of simple. These symptoms have to last for at least once a month. For more than 1 month. Symptoms have to impair your important areas of functioning, and these symptoms can't be due to substances or any medical conditions. So, insofar as we're talking about PTSD today, this is how we're defining it, exactly how the DSM-5 does. All of these criteria we just went through, this is what PTSD is. Next, we'll dig into what CBT is, or Cognitive Behavioral Therapy. Now, I'm going to give a rough overview of what CBT is. This is not comprehensive. I want to be very clear about that. I'm giving these definitions to give a rough summary so you have a rough idea of what we're talking about. CBT is an umbrella term for many different therapy approaches. You could think about acceptance and commitment therapy, dialectical behavioral therapy, rational emotive behavioral therapy, or exposure therapies. Those are all different forms of CBT, or cognitive behavioral therapy. CBT focuses on the interplay of emotions, thoughts, and behaviors. And I really like the graphic on the right side of the screen because it displays that very well. CBT basically says, if there's a change in one of these three variables, your thoughts, your feelings, or your behaviors, it's likely to cause a change to the other two in some sort of way. Like if you start feeling more depressed, then you're probably going to have more depressing thoughts, and you're probably going to engage in more depressing behaviors. That might be laying in bed for extended parts of the day. That might be socializing less, right? Like the emotion you feel is going to impact your behavior in some sort of way. And this goes with any emotion or any thought or any behavior. It's going to have impacts on the other two. CBT also emphasizes the idea of the cognitive model, which is basically just the idea that situations pop up in your life, and you have automatic thoughts in response to the situation. Good thoughts, bad thoughts, normal, neutral thoughts, whatever. Thoughts pop up in response, and then you have an emotion based on that thought. So if the thought's a negative thought, maybe you're having a negative emotion. If it's a positive thought, maybe you experience a positive emotion. And then whatever the emotion you experience is going to impact your behavior. So it's kind of like the visual on the right side, but it's more strict, saying situations pop up, Then you have a thought and response. Then you experience an emotion and behavior in response to that thought. So it's in the title, the cognitive model. It places a huge emphasis on your thinking patterns and how they impact your responses. Again, this is not comprehensive. This is just a rough overview of what CBT is. And since we're talking about CBT in the context of PTSD, we're going to go through what that looks like. How is CBT applied to PTSD? Again, this is not comprehensive, but we are going to go through some ways that CBT is applied to PTSD. One way is cognitive restructuring. This is a process by which a client and a therapist go through together. First, it's about automatic thoughts. So a client will learn to identify unhelpful or distorted thoughts in real time. And they'll do this with their therapist in session, but the hope is that they can take this home and sort of do this day to day, moment to moment in their lives. So they'll identify these automatic thoughts. And then with the therapist, they'll do what's called reality testing. So together with the clinician, they'll evaluate the evidence for and against the thought. And then they'll develop a rational response. You can call it a balanced alternative thought, a coping thought, or a rational response. But they'll develop some sort of alternative thought in response to the automatic thought that pops up. And sort of dig deeper a little bit, that might look like identifying negative core beliefs. So you might work to identify these underlying schemas that fuel repeated distortions over time. So an example, you might imagine someone who's experienced gun violence in some sort of way. And there's a situation that pops up. They're walking down the street and they hear a car backfire. Now the negative automatic thought in that situation might be, oh my God, I'm not safe. Something horrible is about to happen. Now, if they're working through later a rational response with their therapist, that response might be something like, that sound was just a car backfiring. That was not gunfire. I'm currently safe on this street. That would be a more rational response to the negative automatic thought that emerged in the situation. And if we're thinking about this in terms of core beliefs, because you might ask, okay, why do these negative automatic thoughts pop up? The idea would be, perhaps you have negative core beliefs that inform these automatic thoughts that pop up day to day, moment to moment. So maybe the negative core belief is, the world is nothing but dangerous and I can't protect myself. And that negative core belief is informed by the trauma the person experienced. So again, you would develop a rational response to the person, with the person. So maybe that rational response looks something like, okay, there's a lot of danger in the world, but some places are safe. I have ways to protect myself right now, and I've survived difficult situations before. Now that's a rational response that combats the idea that the world is nothing but dangerous and I can't protect myself, right? This is, again, oversimplification, but a rough idea of what cognitive restructuring looks like. Another way that CBT is applied to PTSD is different forms of exposure therapy. One form of exposure therapy is called in vivo exposure. And what that looks like is a gradual confrontation with real-life trauma reminders and avoided situations. In therapy, this would begin with more moderately distressing situations and progress to more difficult ones. And, in therapy, there's going to be homework assignments to practice exposures between sessions. So if the trauma is a car accident, maybe this looks like starting out by sitting in a parked car with the engine off for 10 minutes while practicing some grounding skills. And we do that over and over until your distress in that situation starts to go down over time. And then maybe we do something a little bit more distressing, like maybe we sit in the passenger seat while a trusted person, slowly drives around the block, right? That's more distressing, but maybe we can handle that. And then maybe if we do that 10 times, the distress goes down. So maybe we do something even more challenging. Maybe you drive your own car slowly in the quiet neighborhood, right? And that's horrifying at first, but over time, the stress goes down, we feel more comfortable doing it, and maybe we go on to something even more scary, like driving on the same type of the road that the accident occurred. And then maybe we eventually progress to longer drives on highways, right? So this gradual exposure to the stimuli that causes anxiety. This is what in vivo exposure looks like. Another form of exposure therapy would be imaginal exposure. And what that looks like is the client recounting the traumatic event in detail in the present tense, guided by the therapist. So this would happen in the therapy session. And repeated retelling across sessions would occur until distress decreases, and you can call this habituation. And afterwards, you process and reflect on changes in fear, beliefs, and meaning. But this is basically the idea that, okay, you may have this trauma, and you may feel like it's absolutely horrible and impossible to recount it. And if someone does recount it, and they can see, okay, I'm safe here, I'm okay, I'm not going to die, I'm alive, right? Sort of, okay, this is something I can do. I can think about what happened, and I can be safe thinking about what happened. And maybe in doing that, I can change my beliefs, fears, right? All of that can decrease in intensity over time. This is kind of what imaginal exposure looks like. Again, this is an oversimplification, but this is roughly what we're talking about when we say, okay, this is CBT, and this is how we apply it to PTSD. Now, an important question is, why is CBT effective for PTSD? Like, why does any of this work? And I outlined why in sort of the form of an argument, so we'll roll with this. Premise 1. PTSD symptoms are maintained by maladaptive cognitions and avoidance of trauma-related thoughts, memories, and reminders. And I believe that there's independent evidence for this, each of these premises. The next one would be that these maladaptive cognitions and avoidance prevent natural emotional processing of the trauma, and that keeps the fear and distress alive. And premise 3, CBT directly targets these mechanisms by the things we just talked about, restructuring maladaptive cognitions into more accurate beliefs, and reducing avoidance through gradual, controlled exposure. So the conclusion of this is CBT reduces PTSD symptoms by allowing adaptive processing of trauma and disconfirming these maladaptive beliefs. Again, I believe that there's evidence independently for each of these premises, and this is a logical argument for why CBT is effective. Now, we've talked about plenty related to CBT. What is EMDR, or eye movement desensitization and reprocessing? EMDR, and this is just a rough definition, again, an oversimplification. EMDR is a structured psychotherapy that helps people process traumatic memories and other distressing life experiences by using bilateral stimulation, that's a keyword here, like eye movements, hand taps, or sounds, while the client focuses on the traumatic memory. And that's a very simple definition, so in the same way that we did for CBT, we're going to discuss how is EMDR applied to PTSD. And we're going to go through the whole process. This is what I learned in EMDR treatment, and I've sort of gone back and looked at my notes and written all this out. Again, it's kind of an oversimplification, but we're going to go through each of the 8 phases of EMDR as the people who make EMDR define it. So, what does this look like in therapy? First, there's phase 1. There's a history taking and treatment planning process. So they define the target memory or the trauma, and we're going to go through an example as we go through the phases. So the example we're going to go with is a car accident. So we identify, okay, there's the car accident. What are the triggers? The triggers are intersections, screeching brakes, and we'll define, okay, what's the desired future goal? Maybe that's driving calmly and independently. So we identify all of those things, the target memory, the trigger, and the desired future goal. Phase 2 is preparation. So the therapist explains the EMDR process and helps the client build some coping skills. That might look like a safe space visualization or a paced breathing sort of strategy, right, to regulate our emotions in the moment. The next phase, phase 3, is assessment. So the client selects a specific image that represents the memory. In this example, we'll just say that's an image of headlights right before the crash. And then the client identifies a negative cognition. So the negative cognition is, I am not safe. Then the client chooses a preferred positive cognition. We'll say, I am safe now. And then the client rates the validity on a 1 to 7 scale. I don't know why it's 1 to 7, but a 1 to 7 scale of the negative cognition. So maybe the negative cognition's at a 7. And the positive cognition's at a 2. So we don't really believe the positive one, but we really believe the negative one. Then the client reports current emotions and body sensations that are associated with the memory. So that might look like fear, tightness in the chest, things like that. And then the client gives a baseline, we call it a SUDS rating, a subjective units of disturbance rating. And maybe that's a 9 out of 10. Like whenever they think through these things, they feel very distressed. If they had to rate it, they'd say a 9 out of 10. The next phase of EMDR is desensitization. Bilateral stimulation, which looks like eye movements, tapping sort of your chest back and forth, left and right, or auditory tones, they start doing that. And if you don't know what that looks like in the session, that looks like a therapist waving their finger back and forth and asking the client to focus on that. While they focus on the next part, they're asked to focus on the memory and the related material. So look at my finger, waving it back and forth, and focus on the memory. And then they do this. The processing continues until the memory becomes less disturbing. And they might rate it at a 3 on this scale. The next phase, phase 5, is installation. So they continue this bilateral stimulation, and the client is asked to focus on the positive cognition that they chose in phase 3. So that was, I'm safe now. They're asked to focus on that idea. And then the clinician asks about the validity of that positive cognition. How valid do you feel like that is on a scale of 1 to 7? And then they just continue that until the positive cognition feels valid to the client. So they're at maybe a 6 or a 7 on that 1 to 7 scale. Phase 6 is a body scan. The client is asked to mentally scan their body for any physical tension or disturbance related to that memory. So maybe they feel a tightness in their shoulders, and they feel like that's related to the memory. And if that's present, then they continue processing until that tension or disturbance decreases. Phase 7 is closure, so the client returns to a sense of stability. The clinician ensures that the client's grounded, and coping skills are reinforced. So maybe we use that safe space visualization that we talked about earlier. We use that coping skill in the moment to get that feeling of stability. And phase 8 is reevaluation. So at the start of the next session, the clinician checks in on previously processed memories, current symptoms, and progress towards their treatment goals, and they identify new targets if they need to do it. And that is EMDR. That's a rough summary. It's a rough summary, but that's more or less how they would describe the process. You know what EMDR is now. The next important question is, why is EMDR effective for PTSD? This is where I start kind of getting into my opinions, but roll with me here. Nobody knows why it's effective for PTSD. Now, there's theories, we have different ideas, and I'm going to talk about these ideas, but there's not significant evidence that we know absolutely it's this model or it's that model. We don't necessarily know why EMDR is effective, we just know that it is. Research bears out the idea that when you do EMDR, it's roughly as effective as doing CBT with a client who has PTSD. So we know it's effective, but we don't know why. What are these theories? The first one is the adaptive information processing model. The idea here is that traumatic memories are stored in maladaptive, sort of quote-unquote frozen state, disconnected from healthy memory networks. And the idea is that EMDR reactivates these memories with the bilateral stimulation, and this allows the brain to reprocess and integrate these memories, reducing their emotional charge. That's one idea. Maybe that's why. Another idea is the working memory and dual attention model. So this is the idea that holding up traumatic memory while doing a demanding task like the eye movements taxes your working memory, and this reduces the vividness and emotional intensity of the memory, which makes it less distressing over time. That's another idea. Another one is this idea of the orienting response model. So the bilateral stimulation triggers the brain's orienting reflex, which is a natural response to new but safe stimuli. And this produces a relaxation response and greater attentional flexibility, which helps trauma memories feel less overwhelming. That's another idea. Another one is the REM sleep theory, basically. The idea that EMDR eye movements resemble those of REM sleep, and we know that REM sleep is critical for processing emotional memories, so maybe the bilateral stimulation mimics REM-like processing and helps the brain digest these traumatic memories. The last idea, and there's other theories too, but these are some of the more common ones. The last idea is something that I tend to think, which is that EMDR works mainly because it involves a structured exposure to traumatic memories in a safe setting, just like CBT does. Repeated recall in this context reduces avoidance and weakens conditioned fear responses, just like it does with CBT. I tend to go with that, but hey, it seriously could be any of these other theories. We just don't know yet. We don't have enough evidence to say that yet. Now we're going to go in slightly a different direction for just a second, and I'm going to bring it all together, but just go with me here. What is purple hat therapy? You've probably never heard of this before, and that's fine. We're still going to go through it. What is purple hat therapy? I want you to imagine that a psychotherapist insists that clients wear a purple hat during their sessions. And while clients wear the purple hat, the psychotherapist provides CBT treatment. And the clients improve over time. So the therapist says, "I figured it out. When clients wear a purple hat in session, they make great improvements." Now, is purple hat therapy effective? Yes. Is it effective because of the purple hat? No. Purple hat therapy is a treatment that appears effective, but the mechanism is unclear. We don't know exactly why it's effective. So the improvement may come from factors outside of the unique component that's being promoted, right? The purple hat's being promoted. This is why it works, but we don't know that that's why it works. It's probably not why it works. This is the idea of the purple hat therapy. Now, here we are, finally at the topic of why I don't provide EMDR treatment. There is no evidence that the bilateral stimulation that's a part of EMDR does anything. There's no evidence that it impacts the outcomes. We have studies that remove the bilateral stimulation from EMDR, and they show the exact same level of effectiveness of treatment as EMDR with the bilateral stimulation. To me, that seems like the bilateral stimulation is nothing more than a purple hat. And would you insist that your client wears a purple hat during treatment? Obviously not. We don't know exactly why EMDR is effective, but it does not appear to be due to bilateral stimulation, right? So the eye movements, the tapping, the sounds, whatever the bilateral stimulation is, there's not sufficient evidence that that does anything in therapy. And because we don't have evidence that that does anything in therapy, that's not something that I want to include in my treatment. And it doesn't make much sense to do EMDR without the bilateral stimulation, because it's in the name. The eye movements are proposed to be an important part of the treatment, even though there's no evidence for that specific part of the treatment's effectiveness. This is the main reason why I don't do EMDR. There's a couple other reasons, and I'm going to get into them in just a second, but this is the main reason. If we have a treatment that has eye movements in the name, and there's no evidence that the eye movements do anything, I'm not going to do that treatment. And that seems fair. What are the other reasons why I don't do EMDR treatment? Another big one is this training exclusivity. So the EMDR International Association, or they'll call it EMDRIA sometimes, tightly regulates training and certification. And this is not super common in the field of psychotherapy. Most other effective approaches don't require any sort of certification. Now, certifications can be good and can show evidence that you've been specifically trained in a specific area, and that's fantastic and that's amazing. But most don't require it. If you're learning about CBT, you can go to a conference and learn about CBT, and they'll tell you how to do CBT, but they're not going to require that you have the certification to do CBT. Same for acceptance and commitment therapy. Same for different exposure therapies, right? The training is great, but it's not required. And if there's two treatments that are equally effective, and one requires a training that costs hundreds of dollars, and one doesn't, I'm going to recommend that people go to the one that does not. That doesn't seem outlandish to me. There's training exclusivity here that I believe is unnecessary. And lastly, I heard a lot of red flags when I was in the EMDR training. A lot of things that did not sound appropriate. The first one, and I have less of a problem with this first one because how we talked about trauma in the beginning. But one thing I heard a lot in the EMDR training I did was that everyone has some sort of trauma. Now, if we're going with the flexible definition that we talked about, the sort of day-to-day, look, things are traumatic, then sure, yeah, everyone has some sort of trauma in their lives. But if we're going with the DSM-5 definition of trauma, that's simply not true. Amongst those tight description of what trauma is, not everyone has that. And there's a larger discussion to be had about the impact of using a more flexible definition of trauma and how that impacts treatment and the importance of the label trauma. And I'm not going to get into all that right now, but that was one thing that made me raise an eyebrow. The next few ones are a little bit more scary to me. In my training, I heard that EMDR doesn't have to be used just for PTSD. You could use it for depression or anxiety. I don't know how the hell you do that, but that's something I heard in EMDR treatment. That doesn't make much sense to me, especially how we went through the 8 phases and how it requires a target memory and all of that, but I heard that. That made no sense to me. That raised a red flag in my head. Another thing that raised a red flag is this idea that it doesn't really matter if we know why it works. Now, I could see a clinician saying that and sort of running with that, and maybe that's fair for them, right? Like, if a treatment's effective and you just want to run with it because of that, that's fine. That's not how I want to operate my treatment. I only want to use a treatment if I have an understanding of why it works. And I'm not going to wave my finger in front of someone's face if I don't have good evidence that that actually does something positive. Lastly, I heard this idea that, even if you're using other approaches with your clients, even if you're doing trauma-focused CBT, you should really try out EMDR with them because you'd be amazed at how quickly you can get results. And any treatment that promises these super fast results, and the evidence doesn't necessarily bear that out, that also raises a red flag with me. So these are the reasons that I don't provide EMDR treatment. First of all, this idea of there's no evidence for the bilateral stimulation. Like, that seems like a major flaw. Secondly, this training exclusivity that EMDR has, that just seems... It seems like a way to make money. And I'm not saying that the people who do EMDR, the EMDR International Association is making bank or anything like that. I don't think they are. But again, I'm not going to recommend that another clinician do a training and get a certification when there's other therapies that are just as effective that don't require a certification. And I just heard these alarming things in my EMDR training that raised so many red flags in my head. Now again, I want to be super clear. EMDR is effective. It is. We don't know why, but it's effective. So, I'll say the same disclaimer I said in the very beginning of the video. We'll just go right back up to that. I will not tell anybody, if I can get through all the slides, I'm not telling anybody to not do EMDR treatment. If you're doing it and it's effective for your clients, feel free to continue. These are just some of my thoughts. And if you're a client who's doing EMDR and you're getting success with it, keep doing it. I'm genuinely very glad that it's working for you. If you have trauma and you're getting healing in some sort of way, I don't want to push you away from that. But these are the concerns that I have with EMDR, and I just want to be very real about why I don't do it. That's essentially all I have to say on the topic. I really appreciate anyone who's stuck around this long and actually listened to the video. I'm not very familiar with doing much of this anyway. This is the first time I've made a YouTube video. And if you disagree, if you have other thoughts, tell them to me. Like, combat my thoughts. Give me other ways to think about this. I don't mean to be a excessively difficult person on this topic, but I did the EMDR treatment, I did the EMDR training. Saw a bunch of other people around me that weren't asking the same questions I did, and that was concerning to me. So I wanted to make this video, be real about some of my thoughts about EMDR, and hey, if you have different thoughts and you think I'm wrong, challenge me. I would love to be shown to be wrong, because then I would be more right. Because I would change my mind. Anyway, thank you for your attention. I appreciate anyone who made it this far in the video, and I hope you have a great rest of your day. Take care.